This presentation will focus on blood product management and transfusion strategies when caring for patients with acute upper GI bleeding. There are several landmark papers identified regarding the management of upper GI bleeding. These two papers in particular examine transfusion strategies looking at restrictive versus more liberal protocols. In this East Minute, we will focus on the paper by Villanueva et al., published in the New England Journal of Medicine in 2013. Please consider watching our other East Minute on this topic, which covers the paper by J. et al., published in Lancet in 2015. This first study by Villanueva et al. Was published in the New England Journal of Medicine in 2013. This was a randomized controlled trial from a single institution in Barcelona. The study was run from 2003 to 2009, and all patients 18 years and older presenting with hematemesis, bloody nasogastric aspirate, and/or melena were considered for inclusion. You can see the listed exclusion criteria before you. For those of you not familiar with the Rock-All score, this is a system for assessing the risk of further bleeding or death among patients with gastrointestinal bleeding. Scores range from 0 to 11, with a score of 2 or lower indicating a low risk, and scores of 3 to 11 indicating increasingly greater risk. I've outlined that scoring system on this slide. As outlined on this slide, you can see that over 1,600 patients were screened, 962 were found eligible, and 921 patients were randomized. 461 patients were randomized to the restrictive group and not transfused unless hemoglobin fell below 7, with a goal hemoglobin of 7 to 9. 460 patients were randomized to the liberal group and transfused when hemoglobin fell below 9, with a goal of 9 to 11. Team members at this single institution followed a very strict protocol. Hemoglobin was measured at admission and every 8 hours for the first 2 days, following which hemoglobin was checked on a daily basis. The protocol did allow for transfusion at any time symptoms or signs related to anemia developed, massive bleeding occurred, or surgical intervention was required. When transfused, patients received 1 unit of packed red blood cells at a time. The protocol was applied until the patient discharged from the hospital or death. Additionally, patients underwent upper endoscopy within 6 hours with intervention if needed. Proton pump inhibitors were provided if appropriate for disease process. Many of the patients in this protocol had liver disease and were provided somatostatin and antibiotics for management of portal hypertension. Outcomes for this trial included death at 45 days, as well as the rate of further bleeding and untoward events that required active therapy or prolonged the hospitalization. This team found that mortality at 45 days was lower in the restrictive arm when compared to the liberal arm. This finding was statistically significant. Subgroup analysis performed by the research team identified that treatment effect for mortality was significant only for patients with mild liver cirrhosis and did not carry forward for patients with peptic ulcer bleeding or patients with severe cirrhosis. The figure provided comes direct from their paper and details these findings well. Additional results include a significantly lower rate of transfusion in the restrictive group when compared to the liberal strategy group. Clinical adherence to the transfusion protocols was high in both groups. The number of units transfused was lower in the restrictive group. On average, 1.5 units was transfused in the restrictive group, whereas 3.7 units was transfused on average in the liberal group. Rate of further bleeding was lower in the restrictive group. Adverse events were more common in the liberal strategy group. Hospital length of stay was shorter in the restrictive group. Interestingly, no difference in terms of infections, thrombotic events, or pulmonary complications was noted. The study team should be commended for an excellent randomized controlled trial. Despite this, there are some limitations that should be noted. The results provided are not generalizable to patients with massive exsanguination, as this was an exclusion criteria. Massive exsanguination was not defined in the protocol and was presumably left to clinician judgment. Other notable exclusion criteria are listed here. This makes it difficult to generalize the results to patients who often have multiple comorbidities. Additionally, it should be noted that these patients were admitted to a single institution in a highly specialized unit with a strict protocol of care. The outcomes may be difficult to reproduce in another environment. Lastly, the study was not blinded, which may introduce an element of treatment bias. Final word on this study is that in some patients presenting with acute upper GI bleed, transfusion at a restrictive transfusion threshold appears to not only be safe but superior to a more liberal approach in terms of rates of further bleeding, adverse events, and mortality. This is especially true for patients with liver cirrhosis and suspected variceal bleeding. Thank you for your interest in this topic. While this study suggests that a restrictive transfusion trigger may benefit patients presenting with upper GI hemorrhage, larger, randomized, multi-center trials are needed before a permanent practice change can be recommended.